David Ivers with Developmental Disabilities Provider Association. Charlie, I just wanted to provide a little feedback, see what you thought about the encounter data. We understand the need for so-called granular data, but just to kind of distinguish there, just the need to understand what services were provided does not mean that you have to have a progress note for every single encounter. And that's a big difference. And I don't know a lot of programs that have to do as much documentation other than behavioral health, and we've all seen how well that worked. So, I mean, we don't want to get bogged down in all these progress notes because we're putting process, I think, there above outcomes. And I think the second point is just because you need the encounter data doesn't mean the encounter data needs to drive the reimbursement, or you're right back to a volume-driven payment method. So, I mean, the fact that you need to know someone received supported employment or they received DDTCS or whatever it is that day can be done with a check mark on a form and not have to write every single thing that happens every single time you see a person when you're providing multiple services over weeks and weeks for these people. That's just really got to change. And going into this process, that was part of the reason why we felt it was important to sit down, and that was to reduce the administrative burden on providers. And then secondly, I'll just say that I think it goes along with that then you need to emphasize more on performance. But before you can tie payment to performance, we're going to have to do a lot better with the data and health information technology. And we had made some progress on the data we were getting, but I think we've gone backwards, and we're really having a problem getting really usable data. And I think it would really help if the providers could sit down with whoever's going to run the data, whether it's McKinsey or the data lab or whoever, before it's run, and talk about what it needs to be so that it's more efficient and we don't have all these runs that are wasting people's time when the data is not usable. And so, I mean, or it's the University of Michigan. Everybody seems to be doing it differently. Paid claims, or encounters, claims, whatever it is, whether it's claims paid, claims billed, right, the different fiscal years, none of it's comparable, and we're trying to make decisions on pricing, a 3% cut, whatever it is, and we don't have good data.
David, I appreciate, you're preaching to the choir on a lot of that, but I also know that we've got to come to some kind of agreement with our payers that allows them to feel comfortable with us and allows us to not spend all our time like that. Because I hear you on knowing the progress notes all the time, because I'm not sure we have time to look at every one of those, and I don't want to know what everybody's doing every 15 minutes or what somebody's opinion of how well somebody's playing in a Special Olympics basketball game. I like to know they're at the basketball game. And, I want to see some documentation that, there was somebody there, but staff was there. But I don't want to get off on a rant to hear about what would be ideal. And I agree with you on the data. We've got to have good data. I think the fact that we've kind of struggled all through this process is indicative that we've got to develop more robust IT systems. We do a lot of things on paper. Anna's our youngest person involved in this, and she has a look on her face all the time of like that we're driving REO speed wagons and dating flappers. I don't know. She thinks because we use Excel spreadsheets. I promise you there's people in this room who don't know how to use Excel spreadsheet, and to her that's the same as a fax machine. So we got to get there. Because we can't make decisions. I can't even argue with y'all about the data because neither one of us have good data to argue with about a price. But we're getting there, and we'll be able to work with Andy on that. Who else has got a question? Who's next?
Hi.
All right.
This is a follow-up to what we are already talking about regarding the University of Michigan and them setting the client levels based on the assessment and the cost curves. How open are they going to be to us regarding our concerns? And if we have specific recommendations, specific concerns, are they going to they're going to come up with something and give it to us like they did with the assessment, or are we going to have true input and they're going to receive it and use it?
As far as I know, the University of Michigan looks at this as a true data gathering exercise as far as looking at the assessments, assuming that they're accurate, and that's always the assumption that we make, is that they will be able to see this is a very unique group of individuals. They have high medical needs, no behavioral needs. This is a separate set of individuals. They have high behavioral needs, no medical needs, coming up with those areas. So that, as far as they're concerned, they don't really have a dog in the fight. They don't care how it comes out. They're the ones preaching the hardest for as many natural service levels as there really are. In fact, that came out of Mary Jane's mouth over and over and over. Don't try to artificially restrict the numbers. If there are 37, there are 37, and we'll have to work about that administratively. As far as their input, they're simply going to be looking at historical data. Now, where it may come for some discussion is how accurate people's cost reports have been in the past, how accurate someone's plan cost was to really cover their needs. Someone had a waiver plan cost in the past of $50,000, and their family says that was never enough, and that may have to be worked out because that's about that particular person. But as far as what they will do, they will simply hook person to money once we hand it to them. They're not going to be making decisions as to whether that was enough money. That would be more of a decision made back at our place with the input of people, I suppose.
So the episode amount will be determined here at DDS and not by the Michigan group?
They will tell us, I'll just use imaginary level 12. They will say, the people who are all the same and fit into level 12 appear to have a cost, historically, of between $10,000 and $15,000. Then it would be a policy decision as to whether that is the new cost or whether there's some adjustment to it. Is that right?
I would agree.
Okay, he would agree. I am going to go through the transition page really quickly. We hope that we've covered on the left-hand side every kind of transition that might happen under this new perspective. Whether a person's needs change and you go from being eligible for only the expanded or DDTCS model to a comprehensive model, that does require reassessment. The person's needs have changed, new care plan, new episode. When a person shifts between an agency model and a self-directed model, that's just a shift of, there's no reassessment, no new episode period, and you'll see at the end of these it says if you stop in the middle of the month it's a prorated amount, so I don't have to cover that each time. Reassessment change, episode amount, someone's condition changes, they're not changing from expanded to comprehensive, but within the comprehensive model, they're better, they're worse. So that would trigger a new episode, new bundle amount. Lead provider changes, you simply take with you to the new provider whatever you've got left. And if that's been prorated out over a year, it should work out fairly with the exception of this large equipment purchase that Charlie talked about earlier, which that's pulled out separately, and the rest of it then is prorated. But the person hopefully would have that equipment with them to take to that new provider. When services terminate, that's when they stop, they stop. We've talked a lot about selecting and tracking performance measures because in order to see that services work, you have to look at the end. We were talking yesterday about cost and value, and you never know what the value of something is until you've had it for a while. And so we want to be able to say that once we've gone through an assessment and a plan of care and the whole fancy circle of that was on one of the earlier slides, that the person received what they needed, what they wanted, and what was important to them and for their lives. And those things aren't easy to develop. And so we are going to look for provider, family, participant input on what those things are. It's easy to say at the end of their episode someone was safe, someone was happy. But, you know, I have a happy day just about every day, and every day is different. And so it's really hard to say what a happy day is. It's hard to say for some folks, yes, I was safe, but I was miserable. So you have to look at those. Plenty of people get services every day that they are happy with. Plenty of other people get services from that very same provider that they're not happy with. And so we're going to have to spend some time working on this. I look forward to it because if you look at page 16, we have a few things to help us. All of them have some limitations. Yes, we do know where we rank in the national core indicators with the states who are using that, but it's just a sample of 400 people, and we don't link. We're not able to link that back to specific providers. We can't say that one provider is doing better than another because their one person that we surveyed is happier than the person over at provider B. It's not fair and it's not possible. But we do think, NCI is getting busy on how they can expand what they do, expand it to all the other states, and come up with some measures for states that really are effective. We can get some measures from national accrediting organizations. We can look at what accrediting organizations are doing and use some of that. And when I was at a conference recently, we learned that many organizations help states just like ours develop that process, which is not easy to do. It would have to be top to bottom, and it would have to be a process that you had the data to measure and be able to say, you're doing a good job in this area, you could improve. We also have some selfish wishes that besides just doing compliance surveys, we have an opportunity to do real program improvement, sit down with providers in a way that's not, we got you, but it looks like everybody's struggling with support employment or transportation or whatever those issues are, and actually try to do some program improvement. We would tailor that to what Arkansas is, and we would use a lot of different sources, as it says on the bottom. We are looking at some electronic health records. We do, what we're talking about is putting out an RFP for an organization to help us do this, to sit down with various groups of stakeholders and say, what matters to you? What would you like us to measure? Page 17, school-age kids. We have begun this. We have a Children's Assessment Review Subcommittee that's been working for a few months looking at a tool. What do we need to add? What do we need to change? We've had a lot of talk about things that are appropriate for an independent assessor to talk to a family about, and what perhaps is not appropriate to delve into in a 2 or 3 hour interview. And so we're working through that and plan to do essentially what we've done with the adult model and put out an RFP for independent assessors and do that in a time frame that hopefully brings it together with the adult model. It will exclude health services. The episode in the health home should roll out about the same time. It will take into consideration parental roles because that is different for school-age children than it is for adults. And that array of services will look a whole lot like the adult services under Community First Choice.
The assessment, development, announcement, and education period, that's ongoing. The assessment launch, as we've reported, we already managed that. Version 1.5 is what we're calling the school-age kids. Feel like we can get that done in the second quarter, late in the second quarter of next year. We will have to put out an RFP for new assessors. When we do that, we'll probably go ahead and do an RFP for all of the assessors we're going to need to get everybody up and running rather than keep putting out one after another. Our reporting period, data collection, and for both the episode and the health home, I feel like that's going to start in the third quarter of 2013. Obviously, we have to know by then what we want reported, how we're going to collect it, and what we're going to do with it. Feedback period, that's what we're going to do with it. It's that's formal, some informal opportunities for people to be able to, one, as we've talked about today, if we're doing this through a newer IT system or even adapting an old one, we know there'll be some bumps. Sending out 12 or 13 assessors was tough enough to get everything hooked up, so we'll make sure that we have plenty of time to get that settled and that we're looking at the right things. We actually have good data, as we kind of talked about before. Sometimes you're not always sure that what you're seeing is accurate. And then we'll start, you see, after that, subsequently, of course, can mean any time after that. The episode payments start. We really want that to get started in January, or at least in the first quarter of 2014, certainly because we want to take advantage as quickly as possible of the price break that we're getting from our payers in CFC, and also because so many people have been on this waiting list for 5 years, I'd like to help them get off as fast as possible and not say, hey, wait around 6 more months while we make sure that it's absolutely perfect before we get it out the door.